Alex and Pooja are going to present to us the impact of the HOPE initiative on hospital admission for self-harm across Liverpool.
Thank you. So I think this is a service that one of the questions was about before. But yep, so myself and Alex will be presenting today. So we've done a couple of studies with the Clark and now the ARC using some of the hospital episode statistics data. And what we've been looking at is some of the interventions that have been done across the Northwest Coast. And this is one of those studies as well, where we were focusing on self-harm. So there's a kind of a mixed team. We've got clinicians, public advisors, and statisticians, researchers involved in this piece of research. So we've had some information today, a lot on emergency department admissions, but for self-harm specifically, we've got estimated 220,000 self-harm presentations, but I think it's quite commonly known that that's most likely an underrepresentation. Also within that, everything kind of to do with suicide attempts or self-harm is kind of branded together. But there are a lot of presentations that aren't counted as self-harm and maybe put down under physical health issues of lacerations and things. So it's not really that clear, but we've done as well as we can with the data that's available in this study with the hospital episode statistics. So most people won't come to hospital and will be seen within community settings if they go to anywhere at all for help, and 4 to 6% of the population will have self-harmed at some point in their lives. And we've touched on young people today, and unfortunately the rates with young people seems to be going up quite rapidly, especially amongst young women and young girls. And from some other research we're conducting, there seems to be a lot of kind of prevalence with neurodiversity as well, and especially young women who may be waiting for a diagnosis or have a lot more masking as well. So we've seen that this can be an opportunity for suicide prevention, and as we've spoken about all day, it disproportionately affects disadvantaged socioeconomic groups. And within this work, we're going to be focusing on an area that has high deprivation, and in the kind of areas of highest deprivation, we've already heard that you've got people attending at A&Es a lot more. As we just saw in the previous presentation, there's a lot more presentations for mental health. And as I mentioned, for self-harm and suicidality as well, it really crosses over with learning disabilities and autism too. And the area for Liverpool is the 10th worst area in the UK for all post-mental health treatment outcomes. And that's where we're looking at the IAP data, so improving access to psychological therapies. So the point of this project was to have a look at this intervention that was introduced in the Royal Liverpool Hospital back in 2016. And what we were looking at is at an intervention, they offered a brief psychological intervention where people would have 4 therapy sessions weekly. They'd be offered this within a week of presentation at ED for self-harm. They didn't have to have self-harmed. They could have just said that they were thinking about it, and they got one further follow-up session 4 weeks later, so over an 8-week period. Approximately 350 people were seen and received therapy between 2016 and 2022. And within those people as well, everyone didn't necessarily sign up to the therapy, but will have been offered the HOPE therapy, which is, like I say, a brief psychological therapy. So what we wanted to know is, does the initiative impact on the rates of self-harm? So in their kind of pilot study that they did internally, they found that the emergency admissions in their hospital reduced by 50%, but it was on a really small number, just over 1 year. So we wanted to have a look at that against the kind of population data. So our primary outcome was emergency department attendances, and then we looked at emergency department admissions to award, and then reattendance within 30 days as well. And I'm going to hand you over to Alex, who'll talk about the methods and results.
Thank you. So to produce these metrics that we were investigating, we used anonymized hospital episode statistics, and then we also used ONS data to construct other measures to account for in our analysis. The variables were constructed on an LSOA level, so we had a different measure for every LSOA in the Northwest. And we defined the treated area as the LSOAs where over half of the ED attendances from that LSOA went to Royal Liverpool University Hospital. And this was 59 of the LSOAs in the Northwest. And then we used the data from the rest of the Northwest as it was kind of a potential control group. So we were going to use that in some way to control when we're looking at changes over time due to the intervention. And so for this, we used a synthetic control methodology. And this method produces a weighted control group of LSOAs. And it basically allows us to create a very, very similar mix of control group LSOAs so that we can accurately compare the differences, and we can say that these different groups would have experienced similar outcome measures over the study period if it wasn't for the intervention. And so we can assume that most of the changes between them post-intervention were due to the intervention itself. And so to do this, we actually weight the LSOAs based on similarity. So more similar LSOAs they contribute to the control group more highly. And we match them based on demographic factors. We also use distance to healthcare providers and the prevalence of depression in each LSOA. We also matched it on pre-intervention outcome, so before the intervention was actually put in place, these LSOAs, the control group and the treatment group, follow each other quite closely. And we produced this because we matched them on pre-intervention outcomes, we actually used a different control group for every outcome that we investigated. And then we tested for the difference at each time point post-intervention. And so hopefully you'll understand a bit more what I mean. So this is the example of our synthetic control group for the ED admissions outcome. And so it might be a little bit small on the slides, but the little red area is the 59 LSOAs that made up our treated group. And the green bits on the map are the control LSOAs. And they are weighted, so kind of the more green they are, it might be a bit hard to see, but it's just for demonstrative purposes. The more green they are, the more they contribute to the control group, and the more grey they are, the less. And in the end, 281 LSOAs contributed to the synthetic control group. And as you can see in this table here, it shows that they do match quite well on the demographics and other characteristics that we tried to match them against. And so for our results, we can look at the outcomes over time, pre and post intervention. And as you can see, we matched quite well on the pre-intervention period. Obviously, that was specifically matched on, so it does follow quite closely for both the intervention and the control group. But we do see quite a large spike in the control group post-intervention, which isn't what we'd usually expect to see in this kind of analysis. We'd kind of hope for a change in the treatment group and less of a change in the control group or something like that. But in this case, we see quite a large spike in 2018 for the control group and less so in the treatment group. And we think that may be due to external factors. For instance, the release of the Netflix series 13 Reasons Why was released in 2018, which did contribute to higher levels of self-harm nationally. But when we evaluate the intervention at the end of the intervention period, the end of the study period, we see that there is a 63% difference between the two groups. So the intervention group actually still has 63% fewer ED, self-harm related ED attendances than the control group at the end of the period. We also did this for both of the other outcomes. So this is for it says attendances, but it should be admissions. This is for admissions, and as you can see here, they don't really deviate very much from each other, so we don't see much of an effect from the intervention from this. And this is the same for the readmissions outcome as well. They don't change very much post-intervention. They do follow closely before, but that's the way it's designed to be. We also back this up with a slightly simpler matched controls difference in difference analysis. And so for this, instead of using the weighted synthetic control method that we used for the main analysis, we just matched them based on similarity, and we picked 3-to-1, three control LSOAs for every treated LSOA, matched on a 3-to-1 basis. However, this method is not quite as statistically powerful as the synthetic control method, and so we didn't see any impact when we did this analysis. However, we do still see the large spike in the attendances in both the treated and the control groups, which kind of backs up what we were talking about earlier with the possible external factors that might be driving that. I'll hand you back over to Pooja to conclude. Thank you.
Thank you. So we did find a reduction in self-harm related attendances, but we can't kind of take too much away from that because the differences weren't that large. But the large spike, as we said, could have been for external factors. So one reason we've suggested might be the release of the Netflix series that kind of caused a lot of hype globally. And there was some research done, mostly in America, a little bit of research done here that did show increases in self-harm attendances at A&Es. And also another reason why we think maybe Liverpool had less attendances is because there's been the Zero Suicide Alliance and a lot more suicide prevention work happening in the region since 2015. So again, that could have had a positive effect as well in that area specifically. So we didn't see much change with the attendances of reattendances. Results should be interpreted with caution. But what was interesting is that the evaluation was showing local positive effects, but as someone brought the question up before, the service was stopped due to kind of the restructures within the transformation change projects that have happened across the different trusts, and was or is going to be kind of placed within the crisis care transformation change programme. I'm not quite sure if that's happened yet in the hospital it's based in, but anecdotally, the findings of the pilot showed really positive outcomes of having a service like this available, and especially I think the rapid access to a service like this. But in the kind of larger study, we need to do more work on this, and I think we need to have more interventions like this for a longer period of time for us to conduct more research in this area. So thank you.
Great. Very interesting. Shows different research methods that we can use to put a lens on topics such as this. So very interesting. Thank you. And have to express an interest because Pooja and I work on looking at ways to prevent suicide and self-harm in a more community setting as colleagues on grant. So lots of work happening in this area. I was just reading up the 13 Reasons Why, but because I've not seen it, but I can see it's clearly quite contentious. But it's interesting because there were series released in 2019 and 2020, so interesting to see if that was peaks continued or whether it was just a one-off. So
Well, they took some of the scenes out because the Samaritans and some other people did it, and so they took some of the scenes out that they think might have had that effect.
But it's going to be difficult to prove causation.
Mm-hmm.
Any other questions from the audience on this, or can I get us? I'm going to take the advantage to get us back on track time-wise. So thank you very much.
Thank you.